it's a really big mess. It's a Pandora's box that has so many awful consequences that even if you agree in principle with the idea of very, very select cases of people who are suffering unbearably having this as an option, you have to accept that all these things can come with it.
Coming up on British Thought Leaders, palliative care Doctor Cajetan Skowronski tells us why he opposes assisted suicide and euthanasia and explains the pressures this would put on our elderly and vulnerable.
If you give these kind and selfless people the opportunity to remove themselves from society and say this is a perfectly reasonable thing to do, then a lot of them might take it up, not because they don't want to live anymore, but because they don't want to be a burden to others around them.
Dr. Skowronski talks about the risks of legislating for death in a cash-strapped, ageing society.
If we reduce people down to as valuable as they are in terms of economic productivity or cost, then the elderly, the vulnerable, the disabled, they're all suddenly going to be big targets for extermination. And it will be done with a smile, it will be done with kind words and compassionate language, but the incentive is huge.
Welcome to British Thought Leaders, I'm Lee Hall. Today I'm sitting down with geriatric and palliative care Doctor Cajetan Skowronski. Cajetan, thanks for joining us.
Thank you.
One of the main arguments in support of assisted dying is to help people suffering these long, painful deaths and to be compassionate towards them. And you work with a lot of end-of-life patients. How common are deaths like that these days?
No, it's a really good question, because I think a lot of what this debate brings up is a lot of sort of misinformation about death and dying. And so a lot of what the pro side for so-called assisted dying would say is, they say, well, this is all about helping people who are suffering in agony at the end of their lives. And the debate itself actually causes a lot of the public to assume that death is always painful and always involves a lot of suffering, whereas the reality from my clinical practice I see is that most death is actually quite peaceful. Most death doesn't require really any major drug interventions or anything like that, and for those deaths where pain is an issue, we have excellent medication to control for it, and if a patient is plugged into palliative care services early on enough, when they're identified as being approaching the end of their life, all those symptoms that can come up at the end of life can be very well controlled. There are some, and I'd say really very few, very rare cases where it's difficult even for the best palliative care to get on top of pain control. It doesn't mean that they can't improve the patient's quality of life to some degree, and doesn't mean that there aren't other ways in which palliative care can address the patient holistically, help the family, help the patient as well. But I can't lie and say that we always control all pain and all suffering, because there are some elements of pain and suffering as part of being a human that we just can't always avoid. But I do think it's important to get a sense of perspective as to the fact that the majority of deaths are either pain-free on their own, or with good palliative care are very well controlled, and people can be very comfortable. So I think it's a bit disingenuous of the pro-assisted dying side to say that this is about helping people who are in immense pain, because the reality is that in all the countries where this is introduced, pain comes much lower down the list of reasons why people want to access so-called assisted dying. I mean, I don't even like the term assisted dying because it's sort of deceptive. What we're talking about with the current law in the UK that's being proposed is assisted suicide. So a doctor giving a patient a large cocktail of medications which they'll take orally, which then poison them over however long it takes for their body to absorb, which studies from Oregon show it can be anything from a matter of minutes to 137 hours. So that's what we're talking about at the moment. But once you introduce that, you can't really stop it from progressing to outright euthanasia, whereby the doctor directly kills the patient by injecting them with, again, another cocktail of medications, because you'd be discriminating against patients who aren't fit enough to physically swallow what can sometimes be, sort of dozens or even up to 100 pills, which is very hard to do, especially if you are nearing the end of your life.
So, on the subject of assisted suicide, Health Secretary Wes Streeting said he worries that palliative care is not good enough to offer a real choice. What were your thoughts on that, and what can be done about it?
I really respect Wes Streeting's approach to this issue, because there'll be a portion of society and a portion of MPs as well, for whom this issue is quite black and white, of, well, killing is wrong, even if it's killing out of compassion, therefore this is wrong, and it's quite clear for them that this is not the right thing to do. Then on the other end of the spectrum, there'd be a portion of society and a portion of MPs who would say choice is everything, and that freedom that we have should be extended to the maximum, including the freedom to deliberately end our lives. And actually, when you press them, they're saying there shouldn't really be any conditions on that. Anyone should be able to do it. But then in the middle, you've got probably the majority of MPs at the moment, including people like Wes Streeting, who are very sympathetic to the idea that, well, they don't want people to suffer. But And so Wes Streeting has said this in the past, and he's previously voted in favour in 2015, in favour of assisted suicide being brought in this country because of that deep sympathy he has. But I respect him because he looks at the detail. And he's looked at the detail on this. He's looked at what has happened in all other jurisdictions that have brought this in. And he's seen that there is no way that government can safeguard against this being extended to other groups, because you'll always have legal challenges which will be upheld, particularly in the European Court of Human Rights, from other groups of people who are just beyond the threshold that the government sets out. So currently they're proposing it'll either be 6 months or 12 months life expectancy with a terminal illness. There'll always be someone just outside that threshold who says, what about me? This is discrimination. So the slippery slope is undeniable there. And you'll also not be able to safeguard against coercion. So there's no way that you won't be able to, there's no way that we'll be able to stop vulnerable patients from being manipulated into this by family members who often have financial interests, because, doctors and even a judge involved doesn't know what's going on behind the scenes, doesn't know the kind of conversations that have been having. And Wes Streeting has rightly said that this right to die can very quickly become a duty to die, which I think is a very good encapsulation of the problem. But back to what you were asking about in terms of provision of palliative care, that was another one of his concerns on this, is that if this is about choice, currently people don't actually have all the choices available to them, because our palliative care provision is patchy at best. So we've got excellent palliative care where it is available, but currently only 75% of dying people have access to it. Right. So 25%, of the hundreds of thousands of people who die every year is a lot of people who are not having access to the best possible care at the end of their life. And I'm afraid that euthanasia-assisted suicide is very cheap. And it's a one-off procedure, giving people a handful of medications to swallow. There won't be an issue of provision of that. So if you combine those two facts, of patchy provision of palliative care and easy availability of drugs, which probably costs £10 altogether, you're going to have a lot of people who are choosing an assisted death, assisted suicide, because they weren't able to access proper palliative care. And I think West Streeting recognises that would be an abominable failure. And I'm really pleased that he's thought this through. And I think that other MPs who are weighing this up should take very seriously the fact that the Health Secretary, who has declared the NHS broken, says we are not in a position to provide this safely.
We live in an ageing society. People who are old and sick and relying on others to take care of them may feel this indirect social pressure, and then to value their own lives less than the lives of, say, their children, their grandchildren. What kind of scenarios could this create for us?
That's a really, really good point. So we talk about coercion or this duty to die as something that might be imposed externally on our patients. But a lot of the time, from my experience with elderly patients, they come from a generation that was raised to think of others. And that's why they're such a wonderful generation. That's why I've chosen to work with the elderly, because they're, on the whole, such kind and selfless people. But if you give these kind and selfless people the opportunity to remove themselves from society, and say this is a perfectly reasonable thing to do, then a lot of them might take it up, not because they don't want to live anymore, but because they don't want to be a burden to others around them. So I often have situations at work where an elderly patient will have come in for an acute illness, maybe a pneumonia, or maybe they've had a fall or urinary tract infection. We've treated them for it, and then because they've become quite frail, they need some rehab, or they're not able to get home. We need to find them sort of a package of care to help them at home, or we need to find them a care home placement. And that's a time when they feel really low. And some of them just say to me, "Doctor, look, I've worked all my life, I've raised my children, I've always been helping others, I've always been doing things for other people. I can't stand to be in this position of being dependent on others." And they say, "Look, I love the NHS, I'm taking up a bed. I can see I'm taking up a bed. I've been, you treated me in 3 days and I've been sitting here for 2 weeks on the ward. I'm taking up a hospital bed." And they say, "Can't you just give me something, make me go to sleep, not wake up, and then just be done with me, because I just feel I'm a burden." And it's a very sad thing to hear, but in our current system, where we don't have the option of a doctor killing their patients legally, I can turn around to that patient and say, "Don't be silly, you're a very important person in our community, you've done so much for us. We wouldn't all be here if it wasn't for people like you. We owe you. Let us now pay you back for your life of service to us. And when their families are around, they say things like, Gran, we love every moment with you. We wouldn't want, and we don't care if you're in a hospital bed, we don't care if you're in a care home. Like, we love every single moment we spend with you. And the family will demonstrate the sort of the love and the devotion they have to that family member. And the family member will then, cheer up. And they need to hear that from people around. They need to have that clear answer that no, they are valuable, and it doesn't matter that they're dependent on others. We all have our times for these things in childhood and in later adulthood, or if we're sick. And that sense of I want to die or I want to be killed can be treated very quickly by how we react. But if you have a system where death is an option, as in unnatural death, us poisoning the patient, is a therapeutic option, and the patient says that to me, I can't respond like that anymore. The family can't respond like that anymore. We all suddenly have to say, are you serious? Is this something you really want? And we have to explore it as a serious option. So all of a sudden you'll have people who are going through a low moment for whom this low moment might be, the beginning of the end of them asking to be poisoned. And then the doctors will respond, and the nurses will respond, and the families might respond by saying, okay, that's what you want. And there's a very real problem that once something is available and it's seen as an option, people who would never have thought of doing it will think of doing it. We talk about suicide prevention, and it's very interesting looking at the scientific literature on it, that the times in history when suicide rates have dropped the sharpest have been when the means of committing suicide has suddenly disappeared. Right. So there's several moments in history in the last sort of 50, 60 years when we changed the content of gas to have less carbon monoxide in it. So people couldn't stick their head in the oven anymore. That was a way that people used to kill themselves. And now they stick in their head in the oven, and unless they light a match and explode, they're not going to die. When that happened, immediately the rates of successful suicide plummeted. When catalytic converters were introduced to cars in the 70s, which meant that when you turn your car on in a garage, the garage doesn't fill up with carbon monoxide. So that was a common way that people would kill themselves as well. When the catalytic converters were introduced, again, suicide rates plummeted. And if you look at professions where there are the highest rates of suicide, it's not associated with the profession being the most stressful. It's associated with the professional having access to lethal means of ending their life. So farmers, because they have guns and they have pesticides, very high rates of suicide. Amongst doctors, what would you think the highest rate of suicide would be? It would be anaesthetists. Not because anaesthetists have the worst conditions, but because they have the easiest access to the means of ending their life. So the point there is that when the means of committing suicide is readily available, when paracetamol, there's another one, was readily available, you'll have much higher uptake, because when people are in those low times in their life, they can make a rash decision. But when the means are withdrawn or not so readily available, people who would otherwise have committed suicide do not. And then they get through those hard times, and then they'll say, thank God. Thank God it wasn't so easy at the time to commit suicide. And what we're doing by proposing that we introduce assisted suicide is saying the means is always there, and the state will have the monopoly on it. So we'll be faced with potentially absurd situations where someone will come in with a drug overdose, having wanted to kill themselves. We will save them. We will support their organs. We will reverse the toxic effects of the medications they've taken, the overdose they've taken. And then they'll sit on our ward for a while, and then they'll say, no, I really want to end my life, and for X, Y, Z reasons, I mean, unbearable suffering, perhaps they'll be able to establish that they have a shortened life expectancy that would qualify, and then we'll kill them.
As a doctor, I mean, how difficult, you talked about coercion, how difficult would it be to know if someone's truly making a voluntary request for euthanasia and not experiencing external pressure?
So the short answer is it's impossible. As far as coercion is concerned, we can only really act on suspicions of coercion if the patient themselves directly tells us, right, this is something I don't want to do, but my family, my friend, my lawyer is forcing me into doing it. Or if the person who's doing the coercion is not very bright and has been publicly coercing the patient on a busy ward where people can overhear them, and saying things like, if you don't kill yourself, I'll hate you forever. If you don't kill yourself, I'll harm someone in our family. And so we might be able to pick up the cases of coercion where the coercer is not very smart about it. We're not going to pick up the cases of coercion where it's a savvy family member who is concerned about losing their inheritance to care costs and things like that, and so gently, subtly, over the course of many, many weeks and months, suggests to the patient that this would be the right thing to do. And going back to the way that selfless older people will be willing to sacrifice themselves, even if they actually want to go on living, but willing to sacrifice themselves because they perceive that their children will be better off without them being a so-called burden. If you have someone like that, and I think of my own grandparents, if their family members were to suggest just once that, Granny, have you thought about maybe assisted dying, because we don't want to see you suffer anything, they would take the hint very strongly. They wouldn't miss that hint that, oh, my children, my grandchildren are suggesting I think about ending my life. I understand that means that I am a burden to them, and so I'll do the right thing by them, and I'll ask the doctor. And I think that's not inconceivable for a lot of families, that's how things would work. So doctors do not surveil families and their family conversations and what's been going on at home. We can only deal with what's presented directly to us. So we cannot detect coercion if it's done in a sophisticated way, and neither could a judge, because apparently there'll be a judge involved that will write a report and send to the judge to rubber stamp. How on earth is that judge supposed to know what's been going on behind closed doors? So no, we won't be able to detect coercion. Lord Faulkner's bill, which was proposed in the summer, that bill, as part of its safeguarding, talks about coercion, pushing someone into requesting assisted suicide, and how if it were established that there was coercion, the coercer could face 5 years in jail. But it also talks about coercion pushing someone who has requested suicide to revoke that request.
All right.
So, potentially, you could be in a situation where if your loved one is requesting assisted suicide and you try your best to persuade them not to do it, you could be seen as a coercer.
If you try and stop someone.
If you try and stop someone, and if they then revoke their request, once they've made their request, because you've tried to persuade them, and imagine the kind of conversations that would go on in families. Imagine, you love your wife, you love your mother, you love your uncle, and you say to them, please don't do this. We'll do everything to make your life as good as possible. We can't bear to be without you. Imagine someone says something like, we'll never forgive you if you do this. People can say these things out of love, but that could be interpreted as you've coerced them. And so you could have the absurd situation where people are sent to prison for persuading their relatives not to commit assisted suicide.
Flipping things to the doctor point of view, I mean, some doctors may fundamentally disagree with assisted suicide. How would they feel? Can you help us try and understand from their point of view when they have to administer things emotionally, professionally?
Yes. So, again, hasn't been thought through well, partly because it can't be done well. You can't balance all these different interests well. So there would be a conscientious objection clause, which would say that doctors who disagree, who have a conscientious objection to assisted suicide, will not participate. And I think that will probably be respected, at least superficially, to the point that I, as a doctor who doesn't agree with killing patients, will not have to administer the lethal doses of medication to the patient or to prescribe it to them so that they can administer it to themselves. But that does not mean that my therapeutic relationship with patients will not change fundamentally, because whereas now, when I have a patient who is terminally unwell and I say to them, we can't predict these things exactly, but it's possible you're in the last year of your life. The therapeutic focus there is, how do we give this patient the best possible quality of life in the last year of their life? How do we support them, support their families, and support their priorities? That will then shift to being me saying, you are now in the last 12 months of your life, and I'm obliged to make you aware of all the options open to you. You can't define assisted suicide as a therapy and then say to doctors, oh, you don't have to offer it. It's our duty as doctors to give the patient all the options. So even if you have a conscientious objection, you're still going to have to raise it with the patient. And if a patient really wants it, you're going to have to refer them to a doctor who's willing to provide it. And for doctors who see that as killing, that's just separating us by one step from a killer. I mean, we'll be passing the we won't be doing the dirty work ourselves, but we'll be facilitating it. And that's very disturbing. And I've spoken to doctors, and I've seen doctors speaking on this saying, I'm not sure if I'll be able to carry on in my profession. I'm not sure if I'll be able to carry on doing all the other, good things I do if this poison comes into the system, metaphorically and literally.
We saw in the Netherlands there was a legal case about a doctor charged with, accused of sneaky euthanasia. And the Supreme Court ruled that the doctor alone could make the decision if the patient's suffering was hopeless and unbearable to go with euthanasia without the patient's consent.
Yes.
I mean, what are the kind of ethical issues with that? How does that affect the doctor-patient relationship?
Well, I think, that's a good example of the reality of the slippery slope. These things didn't happen when they first introduced the laws. And it always is the case that when the law is first introduced, the first couple of years, numbers are relatively low. Society still kind of takes a bit of time to get used to it, to normalise it. But then within not very much time at all, the use of assisted suicide, or in this case euthanasia, extends and extends and extends to the point where, yes, consent even isn't relevant, because they start talking about how the doctors are making an interest in the patient's best interests, making a decision in the patient's best interests. So it would certainly damage the doctor-patient relationship both ways, but from the patient's perspective, the doctor would become somebody that they can't trust necessarily. Or there'll be a lot of fear, even with doctors who reject assisted suicide and would never be involved with it. The patient doesn't know when they walk into your clinic or they come to the hospital what your particular beliefs are. So you're suddenly part of this profession that sometimes kills people, and sometimes, as in the Netherlands, without their consent. So you're going to get a lot of patients who start to be scared of accessing healthcare, because they'll think, well, if I go to the doctor with this problem, I might end up in a position where the doctor's making decisions for me, or I'm being pressured into this, and it has, from reports I've read in Belgium and Holland and Canada now, it has made some people very reluctant to engage in healthcare, and that leads to knock-on effects because then they're not picking up cancer diagnoses and things early, and then they're suffering because of that later on. So it's a really big mess. It's a Pandora's box that has so many awful consequences that even if you agree in principle with the idea of very, very select cases of people who are suffering unbearably having this as an option, you have to accept that all these things can come with it.
Another one I wanted to ask you about is also Netherlands. In 2023, they had about 9,000 assisted deaths, and 1.5% of those, 130 or so, were people with psychiatric illnesses. And to me, that feels quite worrying that someone could choose to die for a psychiatric illness. Can you talk us about the ethics of that?
Yes. So, it's helpful as well, as we're discussing this in the UK, to realise that 9,000 deaths in the Netherlands would scale up to sort of almost 40,000 deaths a year in the UK if we're just proportionally applying it to our population. So that's an enormous number of people being killed, and here it would be being killed by the NHS. And are we comfortable with that? But specifically on that portion of patients who are being killed for mental health reasons, it's something that has crept in every single jurisdiction that has introduced it, 5 or 10 years down the line. So Netherlands is doing it. There were cases of people in Belgium as well who women in their 20s who were physically completely fit, but one of them had PTSD, and the other one had depression, which she claimed was incurable, and they were, well, I think one was euthanized and the other one was given medications for assisted suicide. And in a way, this is inevitable, because once you define being killed or killing yourself as therapy for suffering, you can't limit it to one group of patients. So if somebody who is in their 20s and suffers with mental health problems says this is unbearable suffering, it is quite subjective. Who are we to say that they're not unbearably suffering? And so logically they have to have access to it. Supporters or proponents of assisted suicide in this country will generally say, oh, no, that's not what we definitely won't allow it. And they always say things like robust safeguards and we're going to have very clear cut-offs and all this sort of stuff. But if you agree with the principle that it's a therapeutic option, you just can't limit it to one group or another. So we have to accept that. I mean, there is obviously a big question then is, if somebody does have severe depression, do they have capacity to make that decision? I would argue not. But there are an awful lot of ethicists and psychiatrists and lawyers who would argue yes. And that's the result that we've seen in these countries. That there was a case in Canada of a lady who'd suffered a head injury and had a complete change of personality and became very paranoid and very depressed. And she stopped eating. She became sort of anorexic and was granted assisted suicide against her family's wishes. Her family tried to have her sectioned because they were saying this is a mental health problem, but they were cut out of the decision. And she was granted assisted suicide and died without the family being present, because in the Canadian case, the doctors and the judge who signed off on it ruled that, okay, maybe there's a mental health element to this, but now she's physically very unwell because she's anorexic. So if your mental health causes you to have bad physical health through things like anorexia, then a lady in her 40s or 50s can be given assisted suicide.
Is that she became frail and that counts?
Yes. So the thing is that if you're starved, I mean, the logic, I mean, it is quite perverse logic, but the logic is this, that if you starve yourself and nothing is going to change there and you continue to starve yourself, you will die from starvation. So therefore, even if you're 25 years old and a rugby player, you will die. So we can say your life expectancy is less than 6 months based on the fact that if you don't eat for 6 months, you'll die. But that means that anyone can say, I'm starving myself. Doctor, what's my life expectancy if I starve myself? It's not even 6 months if you starve yourself, So anyone could qualify as terminally ill on that logic, and it's been confirmed. Legal questions have been asked and confirmed in all states where it's been introduced for long enough. So Oregon accepts this principle that starving yourself means you're terminally ill and means you can access assisted suicide. Canada's bringing in assisted suicide for mental health grounds in 2027. It's actually been delayed a little bit, but they're bringing it in. And Belgium, Holland. So, I mean, as a doctor and as a scientist, we're trained to look at evidence, the evidence base for things. And it's bizarre to me that we've got a lot of real-world evidence for what happens when you introduce these laws, But all the people who are proposing it here are either being naive by saying we'll do it differently here, or being dishonest by saying we'll do it differently here, because they've seen the evidence and they know what's going to happen and they don't mind.
The idea that there's no slippery slope, but if we look at the other countries it's happened in, it seems it's almost inevitable.
Yes, it's unstoppable. I mean, the best argument that people have made based on real-world evidence for there not being a slippery slope is the Swiss model of assisted suicide. But the reason there isn't a slippery slope there is because there's never been any restrictions on who can do it. So you can't fall further down the slope if you're already at the bottom, you know. But they say, oh, look at Switzerland, they've had the same laws for 80 years. Yeah, but they've had the same laws because they've been the most liberal in access to suicide of anyone, you know, in a civilized democracy from day one. So yeah, sure, you can't slip down the slope much further than that. But everywhere else that's introduced it with the kind of, you know, limits that we're proposing, within 5 years, within 10 years, straight down the slope, and it's suddenly you know, available to all. You go from Canada, where you had, you know, just a couple of thousand people taking it up in the first couple of years, and now it's 15,000 a year. You know, Holland 9,000, as we said, is enormous for its population.
The president of Belgium's biggest health fund suggested euthanasia to deal with an ageing population and save the government money. Mm-hmm. And we have an ageing population, struggling NHS, these pension time bombs. Do you think there's a scenario we could go towards where there's kind of a euthanasia to save the NHS campaign?
Absolutely, absolutely. I mean, we've already got a quasi-religious approach to the NHS, to the extent that lots of patients in hospital will say things like, I'm taking up a bed. You need to give this to someone who deserves it more, you know. And lots of people come into hospital very sick. And, you know, I ask them, well, how long has this been going on for? And they say, well, you know, months, maybe even years. And I say, well, why didn't you go to your doctor before? And they say, well, I didn't want to be a bother. I know under how much pressure the NHS is, you know. And these are very decent people who, because of our culture of sort of NHS worship, have not been accessing the healthcare that is their right, because they don't want to be selfish. And, you know, that's a really, they're obviously very good people, but they are harming themselves by not accessing the healthcare. But when you have that culture and so many people who think that way, they themselves, number one, will be tempted to take it up in order to, you know, lighten the load on the system. But also administrators and economists will see, you know, the maths is clear. It's like if you, the difference between supporting someone with social care and healthcare in the last year of their life and killing them is, you know, could be hundreds of thousands of pounds. So if you want to balance your books, the easiest way is to eliminate the most expensive so-called burdens in the system. And if we reduce people down to as valuable as they are in terms of, you know, economic productivity or cost, then the elderly, the vulnerable, the disabled, they're all suddenly going to be big targets for extermination. And it will be done with a smile, it will be done with, you know, kind words and compassionate language. But the incentive is huge. And that insurance leader is just being logical about it. And people are going to... I mean, Matthew Paris, the columnist, openly said, we can't afford the elderly and the infirm, so we should celebrate the idea that we can get rid of them. And let's just be honest about it. And lots of people think like that. And I think it's awful, and I think as a society we have to have very firm positions against that. Saying human life is actually, you can't quantify it in terms of money, and the only safeguard that works is saying we don't kill people. That's the only thing that works to stop these things happening.
Dr. Cajetan Skowronski, thanks for joining us.
Thank you.